So thank you very much for the invitation. Thanks for that awesome introduction, and thank you for giving up your evening to join us. And thanks for the invitation to speak on behalf of the QMEL programme. So yeah, I'm an interventional cardiologist. I work at St Barts Hospital, so Barts Heart Centre. So this is a tertiary cardiac centre providing heart attack services for around 5 million people, supplying 10 feeder hospitals with tertiary cardiac care and interventional cardiology. I also do hospital care, so I fly with East Anglian Air Ambulance. This is a two helicopter service operating with the EC145 platform, usually operating a 2 physician and 1 critical care paramedic crew, going to around, so in terms of resuscitation, about 350 medical cardiac arrests a year, so a very different split from maybe the more urban trauma services. And also my deployed role, so I've deployed in the MERT, Medical Emergency Response Team role, providing battlefield trauma life support and trauma critical care in Afghanistan. Getting back to the nitty-gritty of resuscitation, why have a webinar about it? Well, we're still pretty poor at it. And the data suggests that still fewer than 1 in 10 people survive an out-hospital cardiac arrest in the UK. So even if we were able to make very modest changes to push that to 10 in 11, that would be about 1,000 lives we could save across the UK each year. Now, one of my colleagues took me to task on this data last week, and so I've dredged up the London Ambulance Service data set from the year before COVID struck, and they have about 10,000 cardiac arrests per annum, of which 39% have resuscitation attempted. If you look at the age split top right there, 65% are male, 35% women, around 61 if you're a man as a median age, 67 as a woman. And you can see the time splits there. So 999 call to scene time 7 minutes 28, 999 call to CPR 9 minutes 35, and to defibrillation 10 minutes. And the initial rhythm split at the bottom, 22% VTBF, which we might expect would be the most likely to survive, PEA about 30%, and asystole about 50%. If you look across all of those groups of survival, so overall survival, ROSC to hospital, so return of spontaneous circulation, it's about 35%, which is actually higher than outside of London. And overall survival, okay, it's not 10, it's 10.8, but I think that's still pretty poor compared to the Utstein comparator group on the right. So these are patients who have a witnessed arrest, immediate defibrillation, survival at about 36%. You've all seen, hopefully, the chain of survival there, with the important steps being early recognition and early call for help, early CPR, whether that's bystander CPR or telephone CPR, early defibrillation and early advanced care. And a few years ago, we suggested we know where the big wins are in terms of everybody needs to be able to do all of these stages really well. And possibly one of the arguments is that we should be putting more of our efforts into the first 2 parts of that. But I think we shouldn't let ourselves off as clinicians so lightly. I think all of those steps need to be as good as possible. Enhancing the first bit of the chain of survival, what can we do? Well, training all our citizens to do CPR is definitely a good thing and has been shown to improve both the delivery of CPR to patients with out-of-hospital cardiac arrest and also the chance of getting ROSC. So if you look at areas where they started teaching it in schools and areas where they started doing telephone CPR advice, the chance of getting CPR delivered to you if you have a cardiac arrest is greater and your chance of survival is greater. So those simple initiatives, although they are big, do work. In the bottom right-hand panel, you've got somebody there with an app, which is effectively being used to crowdsource resuscitation. So in big city centres, there are often healthcare providers and people who know how to do basic life support floating around. But a cardiac arrest could be happening in the next street and they wouldn't know about it. Whereas using apps like this is Good Sam app. If you haven't got it, I suggest you get it. You could be alerted to the fact that there's a cardiac arrest going on around the corner and turn up there and assist. What does the data show? Well, actually, there are some false activations, but if you have a patient who genuinely has a cardiac arrest and we use an app like this to get them to it, there's a very good chance that if that patient requires it, they will get CPR compared to if the app wasn't used. So these things do work as a way of crowdsourcing resuscitation. Early defibrillation we know is key as well, and every minute we delay defibrillation in VF, we know that our chances diminish. We usually say about 10%. So after some minutes have passed, your chance of being successfully resuscitated is almost 0. So the way of delivering defibrillation is quite contentious. Should they be in open cabinets? Should they be in locked cabinets? Should there be a phone number that you ring and they give you the key, the code to get in? Well, whatever makes it simple is good. And actually, there are fleets now of community first responder schemes covering a lot of areas in the UK, particularly rural areas, whereby the local people will have trained themselves up and will attend at the request of the ambulance service cardiac arrest, when there would be no geographic hope for actually getting a formal ambulance service resource there to provide BLS with oxygen and early defibrillation. And that works. And your best chance of surviving a cardiac arrest is if you have a witnessed cardiac arrest and someone goes and gets a community or public access defibrillator and uses it on you. Even better than if we have to go through the process of activating a first responder scheme. Less fanciful than it might look, but if you can't get a first responder to come to you, then maybe you could get a drone to deliver the defib to the scene, and actually using comms through the drone actually advise the rescuers what to do. So through the emergency activation service, the drone is delivered to the scene with the defibrillator and the ability to speak to you and say, expose the chest, put the pads on, deliver a shock. And there have been some studies piloting, no pun intended, piloting this, looking at all the cardiac arrests in an urban area and seeing what the time saving would have been had a drone been used to deliver AEDs. Now, they're not perfect, they struggle to get down the underground, but actually it's a pretty good way of getting a drone to you. And actually, they found that it was a safe and effective way of delivering the drone with quite considerable time savings measured in minutes, and we know that that's important. Excuse me. Slightly more robust version here. How many cardiac arrests have you been to that are in the middle of a golf course? Okay, and that's really tricky, presents some real difficult geography for ambulances to get to sometimes. So maybe this sort of thing is a solution for that. And in general, defibrillation kit has become much more portable, hasn't it? So on the left-hand side there, you can see that's a currently commercially available defibrillator. And as somebody who goes running quite often in random places by myself, I do wonder whether I should have something like this with me, or more importantly, whether everybody else should have something like you see on the right. So this is a device for which the patent is currently out. This is a smartphone case, which also has 2 sticky pads in it, which can be used as an AED. So I suppose if we all ubiquitously had these in our back pockets, if this was the standard, or 1 in 10 people have had these, the chance of getting successfully defibrillated if you have an out-of-hospital cardiac arrest would be significantly greater. So this equipment is almost available. Now, what if you're staying at home or in a hotel by yourself and you have a cardiac arrest? Well, unless somebody finds you and activates emergency services, you're pretty much going to die from it. So what kit could we use to detect cardiac arrest? Well, this is a study published using a support vector machine to identify agonal breathing. So having listened to loads of genuine 911, 999 calls and use actual recordings of agonal breathing in cardiac arrest patients, you can train bits of software to identify agonal breathing and separate out other things that happen, so other things like snoring or hypopnea or obstructive sleep apnea events. And actually with a very high success rate, you could teach a device to recognize if you suddenly go into an agonal breathing pattern and activate the emergency services. So these are commodity smart devices such as the Echo and the app. My device is all switching on now, I've said it, but the app and the iPhone, you can teach them to listen out for the sounds of impending cardiac arrest and activate the emergency services with a very high percentage chance of being right. So maybe actually before you just die in your bed, something like this could alert the emergency services. Now, once we're doing CPR, how can we make CPR better? In the top left panel there, you've got the thumper, you've got the Lucas device and the Zoll Autopulse. These are all ways of delivering mechanical CPR. But so far in the randomized controlled trials of mechanical CPR versus normal CPR, none of them has been proven to improve outcomes in an all-comers group of cardiac arrests. So the setting for those is they're probably of more utility if we're going to transport a patient with cardiac arrest, or if we have limited rescuers, or if we're doing this on the cath lab table and we can't afford to x-ray the hands of somebody doing CPR, or we're using it to transition the patient onto Ecmo, so extracorporeal membrane oxygenation, so an external heart-lung circuit. So they do have their place. And in the middle there, you can see that it is possible to have an automated robot system, not like C3PO, but to deliver CPR. This has only been done in animal models, but using a live feedback loop, looking at the amount of carbon dioxide coming out of the patient. So using end-tidal CO2 as a surrogate for circulatory adequacy. It's a bit low, we need to press a bit harder and a bit faster, and the machine could maybe look after and regulate itself. How else do we know that CPR is doing its job? Well, its job is to push blood around your brain so that when you get ROSC, your brain is still alive, and also to your heart to enable you to get and sustain ROSC. So bottom left panel here is using transcranial Doppler to look at blood flow with chest compressions in the brain. The middle panel there, we can actually use near-infrared spectroscopy to look for the amount of oxygen in the blood. So you can see as you go along there, the patient is having CPR. When they get ROSC, the amount of oxygenation in their blood does improve. So we could use this to detect whether we're pushing blood to the brain. And actually something quite old hat now on the right-hand panel, that's esophageal Doppler. That's a little esophageal device that looks at the column of blood moving in the aorta. And perhaps we could use something like that to guide whether we're actually doing successful CPR or not. I'll talk a little bit about systems. These are some images I borrowed from the 3RU, the Rapid Response Resuscitation Unit in Scotland, which is probably one of the first specialist cardiac arrest resources in the UK. A team of highly motivated, selected specialist paramedics who were delivered to, who are targeted at cardiac arrest with a little bit of extra equipment, such as mechanical CPR. To enhance their resuscitation outcomes, and it made a difference. And what things do we need at a cardiac arrest? Well, you need order, you need someone to take charge, you need equipment, and you need expertise. And this was a way of delivering that. And there are various different models, but if you're going to make more patients survive from cardiac arrest, you need to send your top level provider, whatever that is in your system, to provide extra manpower. It's very manpower intensive, and also someone to organize the chaos. Okay, so I'm going to talk now a little bit about where we've been developing this in East Anglian Air Ambulance. It seems likely that there's a coronary perfusion pressure threshold that you need to achieve when you're doing CPR. Okay, so it is a holding measure aiming to pump blood to the brain and the heart. If you can't get enough blood flowing down your coronary arteries, if you can't get the heart muscle to be perfused with oxygenated blood, there is probably very little chance that you're going to manage to get your patient out of VF or sustain them out of VF. So if you want to have ROSC or sustained ROSC, there is probably a coronary perfusion pressure threshold that we need to aim for when we're doing CPR. At the moment, we just do it according to the right rhythm. And if we're lucky, we might have feedback devices such as a puck to tell us if we're doing it fast enough and to tell us if we're compressing enough distance. But we're not really measuring what we're generating in terms of flow. So you can see that the formula, coronary perfusion pressure, is basically diastolic aortic pressure minus your left atrial pressure. And actually, there are about 5 equations for this. It might be right atrial pressure, but there is a threshold. To be able to measure this in cardiac arrest, okay, we've got to have arterial access, and we needed a program whereby we could teach safe arterial access. There's no point having a successful resuscitation and having a patient with a lacerated femoral artery who needs gallons of blood and an operation to fix it. So if we're going to get in and measure this, we needed a safe arterial access program using ultrasound guidance, and we're teaching our teams to deliver common femoral artery access and femoral vein access. Femoral vein access essentially so we can calculate offline coronary perfusion pressure, but also for drug administration. And this might allow us to target therapy after ROSC, if we get ROSC, and detect ROSC. Sometimes it's very hard to know whether the patient's got ROSC or not, but with an arterial waveform on the screen and some cardiac motion ultrasound, they've probably got ROSC. Or during CPR, it might allow us to target what we're doing. We're calling this SPEAR, Specialist Percutaneous Emergency Aortic Resuscitation. We've already rolled out one training program to our in-house consultants. We've designed our own pack, so that's the pack on the left there. It's essentially like a coronary angiogram draped pack. No surprises where that inspiration for that came from. And we have 2 devices there. So there's a mini Mac, so a 4 French access set, which we'd use for arterial access, and a 6 French line, which we'd use for venous access. And the ultrasound device you see there is the Butterfly IQ, which also allows us to do ultrasound scanning of the abdomen, fast scanning of the abdomen, and lung scanning as well. So it's a multifunctional probe. You don't have to change probe. It plugs straight into even an iPhone. iPhone we found is a bit small in the pre-hospital arena, or an iPad, so you can see what you're doing. And that's how we've been training using gel phantoms, called the femoral line man simulator, our teams to get access in cardiac arrest pre-hospitally. On the left-hand side of the sort of images you can get, slightly enhanced, but the thing you can see in the middle of the black patch there is the tip of the needle, and you can see it coming through the tissues, and towards the right you can see the femoral bifurcation. So we can know absolutely that we're putting these needles in a place that's safe in the patient. And on the right hand panel here, we can use it, do an ultrasound sweep if this works, to confirm that we've got a wire into the artery. You can just see it in the middle of the picture there. I'll do it again. So we know we've got our wires intravascularly, and we can now go and thread our cannula in. And that's what it should look like, okay, at the end. And what we've got at the left-hand side sheath there, the red one is a 4 French arterial sheath, so we can hook that up to our pressure monitoring device. And the right-hand sheath there is a venous sheath, and we can use it for drug administration and pressure monitoring if we want to. Now, Is this just pie in the sky? Are we being totally crazy? Well, actually, if you look back, there's an American Heart Association consensus statement written in 2013, endorsed by American College of Emergency Physicians and the Society of Critical Care Medicine, advising us, based on animal studies, we know that there is a coronary perfusion pressure threshold, and advising us that actually arterial diastolic pressure has to be over 25 millimeters of mercury. It probably has to be over 35, to be fair, to get ROS. But if you've got invasive monitoring, these are the numbers we should be aiming at. University of Michigan have beaten us to this, and they have an adult goal-directed Cpr algorithm. And you can see here, if you've had a cardiac arrest, you'll do standard advanced cardiac life support, and then entering the pathway. If they're not getting an end-tidal CO2 where they want it to indicate successful CPR, they will place it. They will optimize their chest compressions, switch to mechanical CPR, maybe switch to a cardio pump, which allows them to do active compression, decompression CPR, and also place right femoral arterial and venous catheters and transduce the arterial BP. But once you're in, what can you do to modify that? Well, you can start an adrenaline infusion at 1 mic per kilo per minute and continue until you get return of circulation. You could give your adrenaline boluses, or you could add vasopressin as a pressor agent. We've modified this slightly, so you can see on the, I won't go through this for very long, but there's a rapid assessment phase here where the team arrive and ensure that quality CPR is in progress. So compression fraction greater than 80%, so 80% of the time someone's doing CPR, no pauses greater than 10 seconds, a decent depth of compression, or if you're using mechanical CPR, they've got the machine set up correctly, the position is checked, and it's generating a brachial pulse. We'll then confirm what arrest rhythm they're in. We'll optimize the airway with either an iGel device or an endotracheal tube, and then prep and drape both groins, get arterial and venous access under ultrasound guidance, and transduce the side arm of the arterial sheath. And then we can use our goal-directed Cpr algorithm here to attach an adrenaline infusion to get our aortic diastolic pressure where we want it. And then there's also a post-ROSC phase there, which if you're lucky enough to get ROSC, you have to stitch it all in, consider anesthetizing your patient, maintain venous access and invasive arterial blood pressure monitoring, get a 12 lead, and then transport the patient to definitive care. And we'll talk about that later on as well. And this is one of the crib sheets we have here. So this is a weight-adjusted adrenaline infusion dose. So if we're aiming for 1 mic per kilo per minute, this is looking at the rate of the 1 in 1,000 mini-jet you need to put up, so 42 mils an hour. At the moment, we give a bolus every few minutes, which is equivalent to 3 mics per kilo per minute bolus, and then nothing as that wears off, and then another massive bolus again. So maybe this is more physiological. Maybe this is a way of finessing the blood pressure where we want it, because unless you get that blood pressure up there, unless there's blood going down the coronary arteries, you will not get and sustain ROSC. Now, our Norwegian HEMS colleagues were very successful in managing to employ a new modality for providing endovascular resuscitation. So they've been using Reboa, more about this in a minute, but effectively occluding the aorta with a balloon during the CPR attempt. So they've written up a case series last year, about 10 patients they did, lovely paper, and they were able to document, A, that we were able to safely deliver this, because there are concerns about interrupting a resuscitation attempt to crack on and do this stuff in the pre-hospital arena, but also it did seem to generate more end-tidal CO2, and that's a surrogate really of circulation. And some data in the top right panel published by my Parisian SAMU pre-hospital Ecmo HEMS colleagues very nicely shows that when you compare mechanical CPR to mechanical CPR with a balloon up in the aorta, if you imagine, look at that top left panel, all your CPR action is now being focused on the circulation we're interested in, brain and heart. What about trauma? Well, Reboa has a very strong affiliation with trauma, and militarily, we know that bleeding is the primary cause of death on military operations. And the deaths occur early here. So 90% of patients who die of bleeding on the battlefield die very early on before even reaching a medical treatment facility. We know from our experience in Iraq and Afghanistan that very well-developed systems have been proven to save lives, and even with severe injury. And the data you can see in the middle there, that's basically an ISS, injury severity score, required to kill you, gradually climbing as the service gets more developed, as we're delivering consultant-delivered pre-hospital care, bringing patients back to field hospitals with multi-consultant-led teams, with vast amounts of blood product available. We're able to save patients who previously would not have been salvageable. So to maintain this in future operations, we need an ongoing novel hemorrhage control program, and we've developed that to operate alongside advances in surgery and transfusion. So this endovascular stuff can't exist by itself, but as part of a package. There are some special problems we have as well. So non-compressible torso bleeding is especially difficult. So if you have bleeding inside the groin junctions upwards, combat application tourniquets, pressure dressings, novel hemostatic dressings all fail, and the mortality here is very high as well. And unless somebody can deliver you early blood component therapy and field thoracotomy to get control of your aorta and clamp it or put a fist on it, those are the only possible therapies in most of these patients. If we look at the data sets from America and the UK, so about 2/3 of those who bled to death on the battlefield had torso hemorrhage. And having reviewed the anatomical injuries from a UK series over a similar time, about 20 to 25% of patients who died had an abdominal or junctional bleed that might have been treatable by an endovascular therapy. The other problem in the deployed setting is this: there is one bed in both of those settings there. So there's often a relatively austere surgical setup with the ability to do a limited amount of damage control surgery at any one time. This is what Reboa looks like, and this is what the Norwegians are doing in medical cardiac arrest. And this is in use on the streets in London by London Air Ambulance as a way of controlling hemorrhage. Initially, they were using this for pelvic trauma, but it's now being leveraged into use for basically peri-arrest patients with very severe hemorrhage. So the balloon is delivered into the aorta. You deliver the balloon there, then your upstream perfusion will be preserved. Obviously, that's not a free lunch, and actually all the time that balloon is up, there is a downstream hit due to there being no perfusion to either gut or kidneys or even just the lower limbs. So we've been working on systems, and our American colleagues are working on systems that can autonomously manage the pressure in the balloon to let a little bit of blood forward, to maybe get a bit of perfusion downstream, but not at the expense of losing hemorrhage control. So this might extend the golden hour for these therapies. At the moment, if you leave that balloon up for an hour, you've got a patient who's probably not going to survive. But actually, with a little bit of forward flow, if we can finesse that, we might be able to turn this into a tool suitable for prolonged field care, or where we don't want a massive forward surgical footprint. If we're operating in austere settings and where we need to be mobile, then something like this might be of value. And that's why we're working on this. In this one step further, what about using a technique called SAP? So this is selective aortic arch perfusion. And my thanks to Jim Manning for the photograph on the right and also loaning me some catheters. But this is the idea that beyond Reboa, we can actually occlude the aorta. And if you can see in the panel on the right there, that looks bigger than a Reboa catheter, and it has a central channel that allows us to deliver a few hundred mils per minute of liquid through that. Now, this is born out of early resuscitation studies from the 80s and 90s, looking for some magic liquid to preserve the brain and heart. But actually, if you just retrogradely infuse oxygenated blood, and if the patient's bled to death, then you can get rapid control, rapid perfusion of the aortic arch, perfuse the brain, perfuse the heart, and avoid the patient ending up in cardiac arrest. And there's good animal data to support that. One step further, we could change that to SAP ECLS, so provide external cardiac life support using the SAP device. So it allows us to get aortic control, so bleeding is stopped. We could retrogradely perfuse the aorta and effectively have aortic arch Ecmo. And that also allows us to have perfusion of the brain and heart with access to abdo, chest and pelvis for emergency damage control surgery. And it allows us to control temperature, and I'll explain why that might be of interest in a moment. But this is one of the images I'll show you of, if I can get this to play, of SAP in a cadaveric model. So you probably won't see this anywhere else. So that's the balloon delivering in the aorta. And once that balloon is up, we've got hemorrhage control, and we can use the central channel to retrogradely perfuse the heart and brain and hopefully avoid cardiac arrest or get ROSC if hemorrhage is a major player. Moving on, so this is a video run of us injecting through the central port here, and you'll see we were able to light up effectively the vessels going to the brain and the vessels going to the heart, and actually you can see blood going down the left coronary system there. So that's the first time in any human anybody's delivered SAP, and it basically does what it's supposed to, does what it says on the tin. Now, you definitely wouldn't have seen this anywhere else either. This is, you could also use SAP to introduce access to the coronary. So if you have a medical cardiac arrest, and we're trying to simultaneously, at the moment, we do salvage PCI on mechanical CPR, unless you're lucky enough to have the patient on full VA Ecmo support, eCPR. But something like this could allow us to have limited aortic arch, so heart and brain ECMO, and at the same time, through the same lumen, if it was big enough, allow us to get access to the coronary circulation, so we could do salvage PCI and open up a blocked vessel. So you can see there's a coronary catheter moving around in the aortic root. It may not transmit very well, doesn't matter. We then pull the kit back and actually engages the left coronary. The next thing you see is the left coronary system lighting up. So at the same time as we've got blood flowing to the brain and heart, we can access the coronaries and maybe even do emergency salvage PCI. What about in trauma? What's the next step? Well, there's a thing called extended preservation resuscitation. Okay, this is EPR-CAT, extended preservation resuscitation for cardiac arrest from trauma. So if initial trauma resuscitation fails, including resuscitative thoracostomy, you rapidly call the patient at 10 degrees C, and effectively you end up in a state of suspended animation, stopping the clock. That allows you then to get on and do your damage control surgery, to get the patient onto external circulatory support, and then rewarm them after. There is a study recruiting for patients for that in Baltimore. This is a quote, killing a patient to save his life from the New York Times. This is Star Wars stuff, said Thomas Scalia, trauma specialist at the University of Maryland. If you told people we'd be doing this a few years ago, they tell you to stop smoking, whatever you're smoking, because you've clearly lost your mind. And that's certainly a response you get sometimes when you mention this at meetings. But I hope I'll show you on the right-hand side there that this is all part of a progression from arterial access to REBOA, whether that's for medical or traumatic cardiac arrest, to SAP, and maybe onto EPR. So, drawing to a close now, it's really important after medical cardiac arrest that these patients should go to a recognised centre of care. And that brings up the topic of a cardiac arrest centre. What is a cardiac arrest centre? Well, there is now a European model for this, and it's probably somewhere that does 24/7 primary PCI with an on-site ICU. And this has recently been published as a collaborative document, a position statement in the European Heart Journal, Acute Cardiovascular Care. And in the UK, we've tried to address this. There is variable treatment across different regions. And in the UK, the British Cardiac Intervention Society has recently released an algorithm. It looks busy, it's because it's not a simple thing, but an algorithm for dealing with these patients. Let's look at a patient here. This is a youngish man who collapsed in the bathroom in front of his family. One evening, was given CPR, but was in true refractory VF. So despite multiple shocks, double sequential, double simultaneous shocks, amiodarone, magnesium, lignocaine, he stayed in VF. We took him to the cath lab. This is the blood gases before going on the table, pH of 7.0 there. He's got a lactate of 10. We agreed to put him on the table and then try and do a salvage PCI. I think we've got somebody unmuted there, so you might want to just remute. On the left-hand panel here, you can see this is the PCI being done on the Lucas device here. So you can see there's a Lucas plunger going up and down, and there's also a wire in the LED. And despite fixing the LED, doing a very good job on the LED, we were unable to get this patient out of VF, and he did not survive to get out of the cath lab. So what about a better plan? What about using mechanical circulatory support? This is the ECG of a patient who we had a few weeks ago who died and had immediate bystander CPR by the police. And when he got ROSC, he had tombstone anterior ST elevation. If he came into the cath lab, we planned to do emergency PCI to his LED. We put him on the table and he had another cardiac arrest on the table, but sort of brady PA arrest this time, having had 9 more runs of VF in the ambulance. So at this point, we changed our emphasis to getting him on circulatory support and eCPR. Once this was established, and this is apparently commonly the case, the patient got ROSC. The VF just organises and the heart starts beating. We're able to then do a PCI to the patient's LED, and he's able to have these tubes. So you can see the access pipes there, pretty large, 14, 15 French arterial access, 24 French venous access lines. So big tubes to take blood out, oxygenate it, and pump it back into the patient. We're able to take his heart recovered, and we're able to take those out 5 days later, and the patient made a good neurological recovery. And we built this into the very front end of our cardiac arrest algorithm. So for these patients, we probably need to change what we do, don't we, at scene. We spend a long time at scene currently trying to get ROSC, and actually maybe we should be heading for hospital. And so in young patients who've got end-tidal CO2, so they are having a circulation or they're having signs of life during CPR, we should probably try and develop an eCPR pathway. And there are various models for delivering this, and I'll talk about those in a minute. Last year was a good year for Ecmo. So that's the data you can see from the ARREST trial, a phase 2 randomized control trial performed in the US. And the survival is about 50% in the group who came to the cath lab and went to eCPR. The study was stopped early due to futility in the conventional arm. So the patients who got all the stuff we trained to do, ALS, all of those things, actually did not survive. And the only thing that made patients survive was being in the arm that gave you eCPR. How do we deliver this? Various models exist. These are some photos I took on the Paris Ecmo rescue course. This is the control center in Paris, sniffing out for cardiac arrests. And if there is one that's suitable, deploying the truck, you can see bottom left, with all of the gear and an ecmologist, an ECMO nurse specialist, and a technician to the scene, and they will put you on wherever you need it. The idea being that you will then get ROSC, and they'll then transport you to a cardiac center. This is the ED Ecmo model. So this is the Sharp Memorial Hospital in San Diego. That's Zach Shinar there. They've got some very good podcasts, very dynamically delivered podcasts, and some good data there. So they'll do the ALS as normal in the resuscitation room, but they'll put wires in during the resuscitation so that they do decide that evidence comes to light that either the patient isn't surviving or that they're a candidate. They can then put them onto eCPR. So you can deliver it in your ED. Or you can deliver in the cath lab. This is Dimitris Yiannopoulos, brilliant service where patients are delivered after 3 shocks. They'll be conveyed to the cath lab and they can get them on circulatory support in under 8 minutes. And if that's not good enough, then that's the big Ecmo truck top right there. So that'll be rolling out this year to deliver this at the scene in a similar model to Paris, or to deliver that to the EDs of hospitals that need support. So if they have an ongoing cardiac arrest, then this could be rolling towards them with equipment and expertise. So I've talked long enough now. So hopefully I've convinced you that we need to improve all of the aspects of resuscitation. This is something that happens in the UK around 30,000 patients a year. So major trauma, 20,000 patients a year, but a very good network for dealing with them. Cardiac arrest, 30,000 patients a year with ROS. This is not an infrequent thing that happens. We have there are 45 air ambulance networks in the UK that would deploy at the drop of a hat to a traumatic cardiac arrest. And there are some that won't engage necessarily or as enthusiastically with medical cardiac arrest. We probably need to change that. If we're going to get survivors, we need to have a different approach. Thank you very much for listening. I've talked for long enough. I'll be very happy to take some questions now.
Paul, thank you. That was excellent. I love your slides. And we do have some questions. I'm going to ask you the questions in the order to which they were posed. So a question from is how often is spear resuscitation used during the UK?
Yeah, I mean, I've done 3, so you know, it's very much early doors at the moment. So we've assembled an in-house training program essentially, and we're learning. So I think there's a Swedish organisation, air ambulance organisation, that says they routinely get femoral, venous and arterial access. I don't know what they do with it once they're there, but nobody's reported being able to, you know, there's no real data. But this is about building a program where we can safely deliver access, because actually in the future, if we want to take advantage of any of these technologies, if you can't get into the arterial and venous system, it's all unavailable, isn't it? So we're just trying to build expertise within the organization, but in answer to your question, almost zero. So the only people doing endovascular procedures really as a routine would be London Air Ambulance doing REBOA for trauma.
Paul, thank you. And REBOA, of course, there is a multi-centre trial going on in the UK run by Jan Jensen at the moment, which I think has now got 15 or 17 sites. And I know Leeds and London have recruited well into double figures already. So the technology, at least the rapid cannulation technology is there. And I think many of us are putting arterial lines during CPR at least. I tend to use brachial because I think they're very easy to access, although of course I change them from brachial to radial preferably, and if not to femoral pretty soon afterwards, because radial being a functional end artery and all that. There is a question, I'm just coming down the chat list, has made a comment that it's useful to think of endovascular extracorporeal techniques as a toolkit that can be used up or down and titrated, which I think is a very nice visual model to use. And we have a question from, have you got any experience of stellate ganglion block in refractory VF? Personally, I've got nil, I've not seen it. And other than seeing it on EM Crit, I've got no knowledge. Is that something you've been involved in, Paul, at all?
Not really, no. That's outside my expertise, unfortunately. I've heard of it, but I haven't ever used it. Or I don't think I've met anybody who's used it. There's a sort of adrenergic drive switching off mechanism. Is that how that's being proposed?
As far as I know, I'm very happy to give you a microphone if you'd like to spend a couple of minutes telling us about it. And do you have any experience yourself? No, you don't have experience of it yourself. But for anybody interested, I think we direct you to Josh Farkas and EM Crit. Josh Farkas's website, Polcrit, I think is one of the best educational resources out. And that man's knowledge, and I think his take on published literature is absolutely phenomenal. Our next question is from, and this is hard to answer, I think. So Paul, what's the sweet spot for transitioning from conventional AS to ECMO? I think it's really, really tough.
I've got an answer, but it's based on okay. So patients who survive have got to be on within an hour, haven't they, of having this? So if you look at, if you're not on within an hour of having anticardiac arrest, you're not going to survive. But probably, so I was talking to, so my colleagues at Barts are running the sub-30 study, which is a pre-hospital ECVR feasibility study in London, and I think for them, the sweet spot, the point at which your focus should change is probably around the 20-minute mark, isn't it? And I think that's what the Parisians felt as well, is that if you're not getting success with your normal ALS options at that point, you need to either be heading towards somewhere that can deliver, and where delivers, a swept up eCPR service, but you need to be heading towards somewhere where that's an option, or it needs to be coming towards you. But this is something that's not really delivered as part of a networked thing in the UK. We only have a handful, just over a handful of centres that have ECMO capability. So, but I think you need to think about it early, don't you? Because it's very easy for time to pass in the pre-hospital arena, and you forget that actually an hour has passed and we're still on scene.
I mean, I find the biggest trouble with this is those that you get ROSC for some minutes and then lose, ROSC for some minutes and then lose. And it's pretty tough. There is a linked question. I'm going to come back to your question, because while we're on refractory cardiac problem and refractory VF, I've got a question from, which is, what's your take on esmolol for VF? And there was a small paper published, which I think had around 60 patients in, which made a great advert for beta blockers and the use of refractory VF. And certainly the figures in that selected paper were way above those we'd get with amiodarone or lidocaine. Paul, beta blockers?
Yeah, I mean, yeah, it feels counterintuitive, doesn't it, squirting beta blockers into patients who are possibly hovering on the hairy edge of being in cardiogenic shock. But as an antiarrhythmic agent, it probably makes sense. I'd have to go and look at the data again, but we certainly carry it. The number of times I've given it pre-hospitally over the last however many years, not very many, to be fair. So maybe it's something we should use more. And also, the less familiar anybody is with the drug, the less likely they are to get it out of the bag. So I think that's the other challenge, isn't it? Certainly, amiodarone isn't a free lunch. It makes you quite hypotensive, particularly if it's given a bit on the rapid side. The other thing in the bag is old-fashioned is lidocaine, isn't it? But yeah, I certainly think it should be there. And probably, in our centre, I'd probably take electrophysiology advice. So there are some situations where I'll just terminate it, but most of it I see is driven by ischemia and driven by a coronary event. And the problem there is simple. I fix the tube, the narrowing in the tube.
And I think it's worth highlighting that actually drugs for VF are pretty poor, and the data for amiodarone and lidocaine against placebo is only a few percent. It's very, very easy to overestimate the benefits and underestimate the risks. Any antiarrhythmic, of course, is pro-arrhythmic. So I would love to see a trial of beta blockers. Anecdotally, I do use them, but that's from the influence of Professor Richard Chilling, who Paul and I work with at Barts. I'd like to come to another question, if I may, and this is a very direct human factors question to Paul. From he thanks you for your excellent talk, and he says, do you have any ideas how we can get A, our HEMS colleagues, and B, a cardiologist to view out-of-hospital cardiac arrest not as futile, but I guess as a rhythm disturbance that needs focused enthusiasm such as you have?
Yeah.
So how do we win hearts and minds, guys?
Yeah, I think we have to. So this year is the first time we've managed to sell to our interventional cardiology colleagues a pathway for dealing with these patients. So there was huge national variation, and I think we're gradually getting to a point where people don't, there was a COACT study published last year which showed that actually if you've got an ECG that doesn't show STEMI, you do just as well if you don't go to the cath lab. That's sort of not the point. Those patients, the survival was huge, and they all went to a centre that was capable of delivering interventional cardiology. So I'm going to answer that question to you. HEMS colleagues, yeah, there is a problem there, isn't there? In that the bell goes off, it's a traumatic cardiac arrest. Everyone's really excited and gets in the helicopter and goes off, intubates the patient, makes a couple of holes in the chest, and you've still got a dead patient, but everybody's happy to do that. Yeah, if you said, right, we've got a cardiac arrest happening in village X, in some services there might be resistance. Oh, well, you know, let's wait and see if we're called or if we're needed. But actually, you've got to be flying there. You've got to be heading there, haven't you? To be, okay, fine, get stood down, but you've got to get your skids on. You've got to get your boots in the back of the ambulance to be able to modify the outcome. So I don't know. There is interest now, I think, in the air ambulance community and the HEMS community about doing this, and I'm hoping that that's getting better. Cardiologists, I think we're gradually getting there. Although, you know, don't forget, I also, through doing pre-hospital work, have to interact with other cardiology colleagues who are maybe less keen than I am. But I think we are getting there. I think a national pathway saying this is what we're going to audit, this is what we expect. So if you're an out-of-hospital cardiac arrest and you had VT or VF, we expect you to accept that patient in your centre. You don't have to put them on the table because there are still quite useful futility scores. But if they've got STEMI and they've got a favourable, favourable neurological outcome score, you should get on and do them. And we will, and we're quite good at publishing all our data internally. We show it to all the other cardiologists. We know who's best at daughter balloon times. We will know who, some centres don't put any ventilated patients on the table ever. So we'll be able to identify them and gently encourage them using the power of national audit, I hope.
And it's worth remembering that the mean age of out-of-hospital cardiac arrest in most studies is 62, 63 years old. You know, these are young people with now many years of life and productive life ahead of them. There's a couple more questions before we move on, Paul. And the question from, does Paul think that we should run adrenaline infusions in cardiac arrests? And of course, you know, paramedics given us this whole tantalizing question of lots of ROSC and maybe a bit worse neurological survival. And there's been so much phone debate about doses and giving infusions and whether we should give smaller doses. And you've touched on this, of course, with selective arch perfusion. What's your take on running infusions? Do you follow the ALS algorithms for adrenaline? And I'll stick my hand up, and I don't. I certainly don't.
I often say I wouldn't give a milligram now. And actually, we know from some of the animal data and again in the 90s and early noughties that actually, if you give the adrenaline, you do get better coronary perfusion, you get a better aortic pressure, but actually at the expense of cerebral circulation. That may be what we've seen in some of in paramedic 2 data. You do seem to get a reduction in cerebral blood flow at the expense of coronary blood flow, and maybe that's what we're seeing. So do I do it? I don't at the moment, until we've properly got this program launched. I don't do it yet. And actually, it takes up quite a lot of, there's quite a lot of stuff going on, isn't there, at pre-hospital cardiac arrest? And my poor CCP colleague is trying to support one doctor is trying to intubate, and I've got some packs open down the other end, trying to do an I-stat to measure their ABGs and various other things. So there's a lot of stuff going on. So we're maybe not there yet, but I don't think doing things that are non-physiological makes sense to me. Yeah, so that would be my question to answer to that. And
has made some good points around that in the chat and the physiological approach.
Yeah,
so there's a few questions really with the same theme, which is, how do you select your patients for SPEAR? How do you select your patients for Reboa? Well, let's leave Reboa aside and just stay with cardiac arrest.
I think you've got to choose.
Who do you fly out to in the helicopter? Because you're not going to fly out to a 95-year-old incontinent, bedbound, someone in a nursing home, but you're going to fly very, very quickly for a 62-year-old on the golf course. So who do you select for SPEAR? Who do you practice a more invasive approach to?
I think the case selection thing is going to be very like the early days of HEMS, isn't it? So having clinicians in the control room who can sniff out using their spider sense the jobs that you might be of value at, or a job that hasn't maybe even come up as a cardiac arrest yet that they think is going to be one. I think that's very valuable. So tasking is very important, and clearly you want to be going to patients who are likely to be survivors. It might mean you have to over-attend a little bit. It's interesting that the Parisian algorithm or process for selecting patients doesn't really rely on presenting rhythm. If you think about it, if I blow a balloon up in your left main stem, patients don't always get VF. They often just slow down a bit, go about, the blood pressure drops to 30, they get a bit of bradycardia, hypotension, and then they just stop. So VF, although it will help us select out the patients who are good cardiac arrest to treat, it's not the be all and end all. So the Parisians would use signs of life during CPR, movement, patients who try and who are cerebrating, trying to interfere with the kit. So that does happen in patients who are really on the cusp of having just lost their output. So I think they're probably where we should be focusing our effort. They're few and far between, but that's probably where we should focus our effort. It certainly will become quite self-defeating if we do this in patients who are unlikely to survive, and then we get this sort of therapeutic nihilism cycle setting up, which is sort of the position we're starting from, really, and everybody thinks, well, resuscitation survival is so dismal, we're going to go through the motions and then stop. But I think we need to break out of that a little bit.
There's 3 more questions stroke points, after which I think we should move on to the next talk, which is a briefer one. So, noted as a HEMS paramedic, it's really tricky to determine who should attend and how to task people. And very, very similar question to that is from, which is stay and play. How long do you spend on scene? And she's made the point, do you think that these additional skills are becoming more readily available, and will they have a negative effect on delayed scene times, and how can we address that? And before Paul talked, my take is this completely depends on your skill set, your transport, whether you stay and bring an airframe out, whether you get to your local cardiac arrest centre. Personally, I do not think there is a general answer to how long anybody should spend on scene, because it depends on the resources of the network you walk in. Paul, what's your take? Yeah,
I don't think the SPEAR stuff by itself is going to be the big win here, and I think something like aortic balloon occlusion with Roboa is a thing that could be a bridge to ROSC. So if you're focusing on ALS stuff, I think that is still very much worth doing and using conventional ALS stuff. But as a way of building institutional expertise and getting femoral access, so that should aortic balloon occlusion become more of a mainstream therapy for medical cardiac arrest, it's already there, and also to allow us to utilize it in the trauma patients who might benefit from it. And by those, that's the peri-arrest patient who's going down the tubes with a blood pressure of 30, whose heart then stops beating because they aren't getting coronary perfusion either. And that's the final common pathway of cardiac arrest, no matter what the cause is no coronary perfusion, heart stops beating, you are dead. So in terms of negative effect on delayed scene times, we probably do need, so if we had hospitals that had amazing PCI whilst on mechanical CPR services, or ECPR services, then yes, we should change our paradigm at that point and shift patients toward them. But I don't think that's going to happen anytime soon. So what we're trying to do is carefully incorporate this in a sort of safe way that we build institutional expertise, so that when the next step becomes available, we're already there to do it. And in the meantime, if modifying aortic diastolic pressure makes a difference, then great.
And the last 2 questions. So from second question, in refractory recurrent VF arrest in a patient having a confirmed STEMI that has been refused by your local lab, should we use thrombolysis? And he's gone back to the old Hamburg-based Troika trial, which was obviously negative, but we know that they gave this stuff late, and we know that many clinicians wanted to thrombolyze in that trial. So those that got into the trial were already those that the local clinicians didn't have faith in. So Troika is a bit of a difficult thing when we look at the details behind it. So Paul, would you thrombolyze if you couldn't get a PCI?
I used to say, it was a dirty word really in the age of. You could try it in that setting. I mean, if your centre won't take them because they're having a bit of ongoing cardiac arrest, then you need to choose another centre to take your patients to, or give them my email. Because I think that's the sort of on-call sport that you should be expecting if you're an interventional cardiologist, and ideally you should be phoning your mechanical circulatory support colleagues or doing it yourself. So you need to have a system of dealing with that. They're quite rare, aren't they? And most people are slightly terrified when they arrive in hospital on the table like that. So yeah, you need to move area and work somewhere like down the road here, where basically the ambulance crews pick the patient up and they just say, we're coming. That's our system. We say our ETA will be X, and then they arrive. So yeah, his question just disappeared then off the screen. Hang on a minute, what was the other bit of it? There was another part to that, wasn't there? But I think yeah, could you give thrombolysis in that setting? Yes, you could. Have I known it saved lives in that setting? Probably not, to be fair. And I think actually, if you look at some of the pre-hospital thrombolysis data, about a third of the patients it didn't get vessel reperfusion, so it doesn't do what we think it's going to. And it's certainly, if you look at Troika, you certainly get bleeding complications afterwards. But as a last-ditch thing, it's not unreasonable, is it? It's not unreasonable.
And it's not so expensive these days either. And for our last question, thank you to how much resource should be spent on resistant cardiac arrest? So what do we throw into it? I'd say this is a huge problem where I'm based now in Qatar, where there is a lot of pressure to continue CPR, in some cases from families, in some cases from staff. So we solved this by introducing the CAHP, which is a French neurological prediction tool. And many of you will be familiar with the Miracle tool from London, because this is all about neurological survival, isn't it? So my take is I use a validated tool to predict good neurological survival, and that guides how far I would go in terms of time. Paul, what's your take on this?
Yeah, I think that's right, and we've built Miracle 2 score into our process, and there's a mini Miracle score in the offing as well for simpler use in the pre-hospital setting. So I think that's useful, isn't it? What we're certainly not going to be able to do is carry people away on a journey if we're just doing futile patients, excuse me, all the time. So we want to choose patients who are going to be winners, patients who've actually got a viable chance of survival. So I think as the scoring systems emerge, we should just need to keep our eyes to those, don't we? And for us, it's Miracle. For you, it's a different one, but yeah. Okay, good, excellent.
Paul, that was awesome. And thank you for sharing your phenomenal knowledge with us. So for the second and much smaller part of this talk, I would like to tell you about the MSCs that we offer at Queen Mary University of London. And these two MSCs that Paul and I are intimately involved in. There's the Emergency and Resuscitation Masters, which has been going now for 4 years, and some of you in the room have honoured us with your presence on that programme. And this year we're releasing a new MSc, which is called Tactical, Military, Austere and Operational Medicine. Now, these are 3-year programs to MSc level and 2-year programs to diploma level. And I'd just like to spend a few minutes talking to you about them. So why would you want to do an MSc in Emergency and Resuscitation Medicine? Why study it? Well, for many of us around the world, resuscitation is our passion. It's the subspecialty of medicine, be that emergency medicine, intensive care medicine, anaesthesia, that we enjoy most. It's where we wish to develop expertise. It's where we wish to focus our clinical shifts, focus our reading, focus our research. And for many, there is an argument that resuscitation medicine is indeed a subspecialty. And it's a subspecialty that crosses many, many specialties, and our faculty reflects that. Now, when I say a subspecialty, I mean, as some of you may choose to develop toxicology or pre-hospital care or POCUS or major incidents. And while resuscitation medicine is less than 1% in numbers in ED, it certainly demands a great disproportionate resource, both in cost and human factors, and also the odds of survival are tremendously altered by the way you approach them, the care you give, and of course the resources you have. So what we are trying to do is to get an MSc for you people that share this passion, to bring together a series of talks and tutorials to help you improve your patient care. As I said, this is a clinical MSc. This is not a research master's. We are aiming to help clinicians develop and to evolve a greater knowledge base than perhaps their conventional training schemes would offer. We hope that this helps you develop leadership roles. Now, that might be leaderships on shift, that might be leadership in education, and for some of you, of course, this may give birth to a passion for research. So for the tactical, military, austere and operational medicine, we've developed this from emergency and resuscitation because we had a number of inquiries from nurses, paramedics, doctors, physician assistants that had a military or paramilitary role. So this includes people that work in SAR, people that are deployed, people in heart, people that have got a particular interest with running the Cbrn service for their ambulance, for their hospital, people working with police, and also from people that are being deployed to remote areas, perhaps to oil rigs or to Antarctica. So what we've tried to do is develop the emergency and resuscitation medicine to put a bespoke product together for the needs of these people. For the emergency and resuscitation medicine, as I've just said, this is for people that have a passion for resuscitation, want to develop skills, and who are based either pre or in hospital and have this interest in acute care. Now, both MSCs are open to nurses, paramedics, doctors and physicians assistants. We do want some clinical experience. We used to demand 3 to 5 years for paramedics, but a number of paramedics have pointed out they get clinical experience during their training, so we've reduced that a little. But what I would say is we do assume a fair amount of knowledge, and you will get far more out of this if you apply with some years under your belt. The faculty is divided into 2 parts. We have a core faculty and a wider faculty. The core faculty develop the programs, they run the tutorials, they develop the questions. Paul and me, you know, the faculty includes Steve Bland, who is the NATO head for Cbrn, Bill Justice, who is Vice Dean of a US medical school, a paramedic and a firefighter, and military man with 30 years experience, Ben Bloom, who is senior lecturer at Queen Mary and academic lead for Barts Health, Tessa Davis, who set up Don't Forget the Bubbles and is a paediatrician and emergency physician at Barts Health, Libby Thomas, who is an emergency physician at King's College London, who has a PhD in simulation, and she leads in our summer school in simulation, Stephen Thomas, who is the ex-director of the training scheme at Mass General and now works out in the Gulf and leads the largest emergency department in the world, as far as I'm aware, in the rich world, I should say. It's perhaps much larger ones in some of the poorer countries. Daryl Wood, who's a South African emergency physician, recently moved to the UK with a PhD in snake bite, and Chet Trivedi, who's an emergency physician and maxillofacial surgeon, who has got both a PhD and an MD. And this, of course, is our wider faculty. Our wider faculty is drawn from, it's Libby top left, and we've got Chris Cabal, who's a professor of emergency medicine at Mass General and Harvard. We've got Brian Burns, who many of you may know from Life in the Fast Lane, and director of Sydney HEMS in Australia. Gareth Davis, who set up London HEMS. Maurizio Ciccioni, who's currently president of the Intensive Care Society for Europe. Next is Chet. Next we've got Barbara Backus, who developed the heart score that many of you will know, and so on. I'm not going to name all of these people, but we have been so lucky to be supported by a number of world-class educators and world-class researchers that have given us their time and expertise to put together our lecture programme. So what we propose here is a level 7, that's a master's level diploma or MSc. Now, unusually, we run the MSc over 3 years and the diploma over 2 years. We chose this early on because when we spoke to potential students, most of them said, look, I want to work full-time, I want to keep working, and you know, I love acute medicine, emergency medicine, pre-hospital care, anaesthesia, emergency nursing, but all of these jobs mean I work weekends, I work nights, and actually I want to learn slowly so I can implement this knowledge into my practice and slowly build up. So we made a very active decision to deliver over 3 years. The first 2 years consist of taught modules where we release lectures, and that is between 2 and 7 lectures each week. And you listen to these in your own time, on your own computer. There is no need to join us at Queen Mary. And we want this product to be open to people all over the world. That said, we want to develop summer schools. We've got a program, we're all ready to go. And then, of course, COVID came, and COVID was not good for summer schools. So we're still waiting to launch our summer schools. For those of you that want to do a MSc, you currently have the choice of a 10,000 word thesis or a 3,000 word scientific paper. We will be shortly moving solely to the scientific paper, and this is from feedback from students that said, we want our third year to give us something that helps our careers, helps our CVs. We're not here to do research, we're not training to do a PhD, but we would like to publish something. So the output of your third year is a paper that we hope you can submit for publication, and based on that paper, a presentation which will be modelled on the sort of presentation you would give us at a conference. So let's look into the structure in a little more detail. So both emergency and resuscitation and tactical, military and austere medicine use the same program, and they share much material. In year one, we start with Ben Bloom's modules, which is the fundamentals of research. We teach you to read papers, to find papers in the literature. We talk a little about foam site access, about PubMed searches. We discuss various critical appraisal tools. We want to teach you to read papers and to form your own ideas. We do talk a little about research methodology, basic statistics, and of course we try to teach you to develop your style in scientific writing. Module 2 is a module I run, and this is looking at the physiology of shock and shock syndromes and the tools of resuscitation. So we look at the underlying pathophysiology, and by tools of resuscitation, I mean talks on catechismines, on inopressors, on the variety of fluids, both clear fluids and blood products that we use to resuscitate our patients. In module 3, we move on and we look in detail about cardiac arrest, airway management and analgesia. And then we end this module with a short introduction to emergency resuscitation pediatrics. Module 4 is run by Paul, and this is emergency care. In this module, we have a series of talks that look at the wider range of emergency medicine and the conditions that are often affected or underpin shock and resuscitation. So talks on cardiac ischemia, talks on assessment of ischemia, pulmonary embolism, stroke medicine, and so on. In year 2, we move on to a focused set of topics. We start with the emergency management of severe trauma, run by Daryl, as emergency physician, and a colleague who is a trauma surgeon from South Africa. We then move into diagnostic tools. Here we have talks about blood gases, ECGs and ultrasound, because these are the key tests that all of us need to be able to do and interpret ourselves, whether we're doing a resuscitation in hospital or in somebody's front room. Now, in year 2, we see the two programs diverge, and we have a module led by Paul on the medical care at the extremes, care on the battlefield. And Paul may choose to say a few words at that towards the end of the talk. Then module 7 is toxicology and Cbrn for those doing ENR, and for those doing tactical, military and austere, we have a larger Cbrn section complemented by environmental medicine. So looking at medicine at extremes of temperature and in harsh environments, submarine medicine, jungle medicine, and so on. Then in the last module, those doing tactical, military, austere and operational medicine will do a pre-hospital and mass casualties module. Those of you that are doing resuscitation and emergency can either do that module or a dedicated pediatric module. And in year 3, we move on to the scientific paper or dissertation. The scientific paper is 3,500 words because, hey, guess what? Most journals expect you to produce a paper of 3,500 words, and the 20-minute talk that is designed for you to give to your colleagues or at a conference. How do we assess you? You know, assessments are there to embed learning. So we're trying to assess you in a range of skills. The assessment should help skill development. So we have MCQs. The MCQs are based on the lectures and are there simply to test the core knowledge that you've picked up from the lectures. We then ask you to do presentations in 2 of our modules. This is because any leadership role in resuscitation is going to involve some teaching, and we hope that by doing presentations within the MSc, that this helps you develop skills at preparing presentations and giving them. We have some critical appraisal exercises where we're going to give you papers online, ask you to appraise them, and then we will appraise them and we'll see how well we agree or not. And this is because at level 7, this is not about you guys following guidelines. This is about you guys going out there, reading, looking at the guideline, looking at its limitations, looking at the literature, and then deciding what of that guideline applies to your patients, what of that guideline doesn't, and then what is best practice, and developing your skill base based on your own decision making. And then of course we've got written assignments. Written assignments are there in part to prepare you for year 3, the MSc, and in part because many of you may want to produce various written assignments in your life, which may be a journal submission, it may be a letter to a journal, it may be a business case, whatever. So we hope that by having this sort of multimodal assessment, we are developing a large range of skills within you. So this is the Blizard. It is a new bespoke building. It's where we're based. It's part of Queen Mary University, London. It is the largest institute. It's an unusual setup. In the basement, we've got proper scientists, true scientists, with a lab. Above that, we've got meeting halls, we've got offices, and we've got some small lecture theatres. So it's a complete combination of science and education. The Queen Mary University of London and the Blizard have been honoured for a number of awards. We've won awards and been the highest placed medical school within London. We're highly placed within the UK for our medical school. The research has been highly cited and highly valued and awarded in a variety of different local and national and international awards. It is a great place to work and a great place to study. We are, of course, intimately linked with Barts Health. Barts Health is home to the largest trauma centre in Europe. It's home to London's Air Ambulance, I think the service with the most critical care experience worldwide for trauma patients. It's the largest heart attack centre in Europe. And of course, this is where Paul works and offers the fantastic service and innovation that he described earlier. We are a research centre with the largest ED, all under one research and development in Europe, which means the team here has a substantial output, and we are probably the oldest hospital in the world. So we're very proud of our heritage, both through Barts and through Queen Mary. So, ladies and gentlemen, I would like to thank you very much for your time and attention. Please do type any questions in. Paul will moderate the questions. And I'd like to just end by pointing out we have upcoming webinars. Steve Bland will talk to us about historical and toxicology cases. It's a great and fun talk that combines some look at history and some looks at toxicology and even some fairy tale characters, and teaches some very important basic toxicological principles. For those of you that are interested in studying with us, we are then going to offer a question and answer session in July, which is where I will give the talk that I'm giving here and invite questions. And we will have our faculty there to answer questions and introduce themselves. And then finally in August, we will invite some of our students to join us to say about their experiences on the Masters, and to, of course, offer the students' perspective, because this is way more important than the faculty perspective. So thank you so much for joining us. I really appreciate the time you've given us. And Paul, do we have any questions?
Yeah, hi Tim, can you hear me?
Indeed.
Yeah, good. So you might, if you unshare, then so the first question is a bit of a gift for you, really. Is from who's saying basically, is there any opportunity to develop POCUS skills? So,
predictably, yes. Now it's very hard to teach POCUS online. So module 6 is around 60% ultrasound, and of that, at least half is focused echo. We spend a lot of time teaching you the evidence base behind ultrasound. We spend a lot of time teaching you how to use ultrasound, and at least how much we can teach online. The summer school is designed to have an ultrasound course. We will probably run 2 courses. One will be a basic introduction and the other will be a more advanced class, and that's where we aim to teach you practical skills. We are also very happy to review cases online. This is something I've done with some of the resus students, and by review online, that means share images, share gases, share ECGs, and discuss the management. And that's certainly something we're aiming to grow.
Yeah, excellent. And so we've put the links as well to the sort of further information pages in the chat as well. So if anybody wants those, plus my Twitter account for everybody who wants to get in touch as well. So there's a question. So this is an interesting point. So how do people tend to fund the studies? He's got previous experience funding a master's with the Career Development Loan back in 2005. Is it the same these days? So what's your take on that, Tim?
So I know we've got some students in the room, and I would very much welcome the students giving their answers if any of them would be kind enough to type in. The short answer is there is a huge range. Some people are funded by their service, either in total or in part. Some people have gone to their service and said, hey guys, I want to do the masters. This is going to help me. Will you fund it? So they've come to one-to-one agreements with managers. Others funded out of their own pocket. Now, masters are expensive, but we have put this masters through at the very lowest band of QM costs. And my agreement in setting it up was that it was banded at the cheapest. I mean, look, I find it unfortunate that we charge for education. I would love to see the government sponsoring all people, just as it does for school, but unfortunately, we're not in an era where that's realistic. For those of you that are interested, one of the ways I was keen to fund was to develop the Resus Fellows. We run a program at Barts Health where doctors are employed, and the Barts Health runs a 2-year rotation and funds their masters in total, and that may interest some of you. Now, that I would love to see that apply to nurses and paramedics. It doesn't at the moment, and that's simply because the only jurisdiction I've got as a doctor is over doctors, so that was the only one I was able to put up. For people joining us from Commonwealth countries, there is a scholarship scheme. That scholarship scheme is pretty competitive, and in fact I've just scored it for this year over the last few days, and we want to grow the scholarship scheme for those joining us, particularly from sub-Saharan Africa and from the Indian subcontinent, for putting in your parts, and anybody else, please do share your methods of funding.
Okay, yeah, so we've got some comments there saying, yeah, some funding from NHS ambulance service. Yeah, there are definitely some ambulance services that will fund it. So yeah, okay, excellent. Well, we're at 7:45 now, Tim. What are your thoughts about? Should we, if we make sure we've got links in the chat there, haven't we? And this will be available. It's been recorded, so it should be available afterwards. There we go. And some upcoming webinars that David's put in the chat there as well. So the ones that are on your slide are there too, and the registration links too. So if you're interested in those, they are free and very interesting. And I've heard some of Steve's talk before, and that is hugely entertaining. And I always would have forgotten all of it as well. So so I would really recommend that one. Yeah, don't tell him I said so, but I strongly recommend it.
Yeah, if you wondered why Snow White died, Steve has the answer.
It's hugely entertaining.
Guys, just as a general point, if you've enjoyed this and you'd like us to do more webinars, please do let us know. These are great fun. I enjoy interacting with you, and without a doubt, I thoroughly enjoy interacting with the students on the MSc. And as faculty, we're humbled. Our students are awesome, and they teach us at least as much as we teach them. And this is very much learning together. I hope some of you are interested. I'd love to study with you. I'd love to learn with you. Paul, that was a fantastic talk as always. Thank you so much. I'm not seeing any more questions, in which case I think we can sign off. Love you and leave you. I would like to acknowledge our colleague David, who organised this. David is sitting there in the background, and I would like to thank him. He's staying, of course, well over his hours too, and none of us would be able to sort this without it. And it's great to see some familiar names. I miss you very much, and is probably one of the best research nurses, if not the best research nurse I've ever worked with, and it's great to see you here. Recruited more patients to more trials than anybody else I've ever met. I think it's a record that will never be beaten. I look forward to meeting you. Great, thank you for joining us. Ladies and gentlemen, to you all, I wish you a wonderful evening. You take care. Paul, again, thanks.
Thank you, everybody. Thanks a lot.